Great. Welcome, everyone. It is Wednesday, January 17th, and you're in the House Healthcare Committee. We have Department of Health with us today, as well as Vaz with us, and I believe Vermont Child Psychiatric Access Program. So we have a whole lot going on about mental health today, which is great. So we're going to do a program review. We also have Representative Tip Bloomley from our Appropriations Committee in here. So we welcome you, and always feel free to raise your hand and ask questions. And I think we're going to get started.
Great. Good morning. For the record, Emily Hawes, Commissioner for the Department of Mental Health.
Alice Croft, Deputy Commissioner, Department of Mental Health.
We also have brought along some content experts. So when we get to that place in our presentation this morning, we'll sub out and then they'll introduce themselves officially for the record. So I've introduced ourselves. We'll also have Samantha Sweet, who's our Director of Mental Health Services, and Jeremy Darian, who's our Director of our Crisis Services.
Great. And I just also want to say we have Vermont Care Partners in the room as well. So we have all the experts in the room, which is great.
We thought we would start off with a re-level set. It's been a year since we were here last. If this is information that you all have, don't want to waste time on it, let me know and I'll move us along. So just a quick reminder, the mission for the Department of Mental Health is to promote and improve the health of Vermonters. The department resides under the Agency of Human Services and has the same critical mission, which is to improve the conditions and well-being of Vermonters and protect those who cannot protect themselves. Our vision, mental health will be a cornerstone of health in Vermont. People will live in caring communities with compassion for and a determination to respond effectively and respectively to the mental health needs of all citizens. Vermonters will have access to effective prevention, early intervention, and mental health treatment and supports as needed to live, work, learn, and participate fully in their communities. So for folks to recall, we are responsible through statute for the mental health system of care. As a department, we have around 302 staff. That includes 235 facility staff for both Vermont Psychiatric Care Hospital and the River Valley Therapeutic Residence. And then we have around 67 central office staff. Our budget consists of around $318 million that supports mental health services to over 25,000 Vermonters. We also oversee 10 designated agencies and 2 specialized service agencies. As I mentioned earlier, the Vermont Psychiatric Care Hospital is a 25-bed hospital located here in Berlin. They serve adults only who are under the care and custody of the commissioner. So folks are there involuntarily, either through the civil court or criminal court.
You said they were there involuntarily?
Correct.
Okay, thank you.
We also oversee the River Valley Therapeutic Community Residence. That's slated to be a 16-bed residential placement. So in the community, it does have locked doors and a fence around it. That's the only level of care that the state has for individuals who are also under the care and custody of the commissioner who no longer meet hospital level of care, but still have some treatment needs in order to transition safely back into the community. We also manage several grants and contracts to peer organizations. We have forensic psychiatrists on contract with us, also the Vermont Child Psychiatry Access Program, and then the statewide mobile crisis. We partner with hospitals, community providers, police departments, courts, and pretty much anybody you can think of. Any questions around that first go around?
Yeah.
Oh, go ahead.
Just what percentage of your 25 beds are used right now?
Sure. They have the capacity to admit up to 21. And there are 9 individuals hospitalized there today.
Right. How about out of the 16 at the therapeutic rest?
There are also 9 at the therapeutic residence there
Okay.
today with a admission pending for next week.
And is it not full due to staffing or? like,
Which one?
Both of them.
Sure. Vermont Psychiatric Care Hospital is can serve up to 21. There's beds open there. If you go up to 25, they would need to add additional nursing staff. But the referrals haven't inclined us to staff. We don't want to staff open beds. And that's what we're currently doing, which is a plus and a negative. The bed is there when somebody needs it. And the system is can fluctuate pretty wildly depending on the day. For River Valley, it is at 9 based on staffing. We don't want to go, what we're trying to do is replace travel partners with permanent and do a 1-to-1 so that we don't go too far over with travel contracts there over that budget.
So just sorry, I know we have 2 questions. Just real quick back to the Vermont Psychiatric Care Hospital. So you are staffing for the full 21?
Yes, yes.
And so how does that equate to what we need for travelers?
Sure. So what the leadership team at the hospital does is take a look at how many permanent staff we have, balance that with the travelers, and we don't want to go over a tipping point where the safety of the facility is compromised. And that can happen if you go over too far with temporary staff, travel staff. So currently there are 9 folks admitted, but they're spread across 3 different units. And so we're staffing those units as if so that they could take new referrals in and also keep in line with the treatment requirements that our Joint Commission folks require us to do. So that's around 30 hours of treatment, active engaged treatment throughout the week.
So are we, we always do this, we stop on the 3rd slide. Do you have more in your presentation about the Vermont Psychiatric Care Hospital, or should we continue
If
on our
you,
lines of questions?
let's do, if you have questions about that, no, I don't,
Okay.
because we were focused a little bit on that last week, but we're doing the whole system, so happy to answer.
Okay, so let's take a couple of minutes. Topper and then Alyssa and then
Yes.
Leslie.
Thanks for coming in. Do you know what the average is in terms of beds being utilized at the hospital
The
over
average,
last year?
I don't, but they covered around 9 to 16, and there's a few components that contribute to that. One of the primary components was a shift from a contract for psychiatry that we had with the University of Vermont Medical Center. That ended at the end of June, and we had a new contractor come on in July. And so during that transition, we needed to make sure that we had enough psychiatry coverage for the number of folks admitted. And so we had to take some fairly creative approaches with that. We had to contract with travel physicians while we recruited for permanent staff. So that lasted from July until about November. And so we at some points had a physician who would work 2 weeks and then leave and have another physician come in for 2 weeks, and then they would offset each other. And so during that time, we were pretty limited with admissions and discharges because we did not want to negatively impact those individuals who needed inpatient treatment from the hospital at that time. So I'd say that's one of the primary drivers for the low census. Referrals for folks who are involuntary and needing the highest acuity have shifted. Sometimes we see a lot of folks come in and sometimes we see none. So like this morning, we had 0 folks to refer to either the open beds at VPCH or the open beds at Brattleboro Retreat. Did that answer your question? Okay.
Thank you.
Mine's just a simple, can you remind me how many beds we need to get down to at the psychiatric hospital for the acronym? To be able to get Medicaid? Yes.
So currently Vermont Psychiatric Care Hospital is operating under an 1115 waiver, which allows us to operate at 25 beds. That facility and the Brattleboro Retreat are what's called an Institute of Mental Disease, and there's a federal cap at 16 beds, unless you have, like we do, in order to be reimbursed for Medicaid, Medicare.
Is that waiver forever and ever?
No, it currently expires in 2027, and we're in a phase down where we're phasing out the Medicare dollars and phasing in general fund.
Okay, so I have a lot of questions, but we're gonna come back to that one. Leslie.
Well, I think you touched on my question. You know, we've heard a lot about people waiting in the ER, and I'm just curious to know how that problem is in relationship to your system.
Sure. That's a really good question. Most folks who present in an ER for treatment are typically voluntary. And some meet hospital level of care. But also some do not. And so an individual may be waiting in an emergency room for a community placement. When you're voluntary, you also have a choice of where you go. So somebody may wait for a bed at a unit that they prefer to go to. So there are some complexities to those waits. They may have some medical condition that require an additional a stabilization, or just to make sure that that's not contributing to what they're experiencing psychiatrically. So that's the open beds, both at VPCH and Brattleboro Retreat, which are the level 1 beds. Rutland also has level 1 beds. Rutland is full right now, but we haven't had individuals present as meeting those levels of care. But most folks, I think almost 80% is the percentage in my mind are going to be voluntary. And those folks can go in state, they can go out of state. There's some choice there, and that can lead to days.
Art and then Topper.
Can I just, sorry.
Go ahead.
So you manage voluntary beds as well?
No, only if an individual is on Medicaid. They are a part of our adult CRT or community rehabilitation treatment program, or they're a youth. So if an individual is voluntary and is on Blue Cross Blue Shield, we don't track that. We know where open beds are, and we could assist with some problem solving if there's a challenging situation there. Regarding placement, but we don't control all of the voluntary placements. Our charge is for folks who are receiving services through the CRT, youth, or are involuntary.
Thank you.
Yes, I'm looking at your hierarchy.
Oh, yes, the pyramid.
The pyramid. And I'm not finding the Vermont Psychiatric Care Hospital. My question was, is that the highest level of the most troubled patients, let's say, are there, or where do they fit in that?
Yeah, that's a great question. So at the top tier where it says level 1 inpatient adult, there's 3 facilities.
Oh,
So there's 3 options for individuals who are in need of additional services in order to serve their psychiatric needs. VPCH is one of them. There's 2 units at the Brattleboro Retreat, and 1 unit at Rutland Regional Medical Center.
but you don't control those. The only one you control is this one.
We control referrals into the level 1 beds across the system. We have contracts with both the Brattleboro Retreat and Rutland Regional Medical Center. And our care management team out of central office will take a look at who's presented and make a referral to an appropriate facility depending on what their needs are.
Well, why is this on your chart and those are not? I'm just trying to distinguish what your,
Yeah, so I'll start with that, Tom, because that's a good question. So over to the far right are those 3 units or 3 facilities with units that can serve individuals who are in the most acute. Oh, I'm sorry, I just assumed you were on there.
No, yeah,
We'll wait till you get there.
yes.
well, I'm on.
Keep going.
So can we, so Art, I'm gonna come back to that, because I think there's still some questions about beds. So we'll come right back to that.
Okay, yeah.
Topper and Melanie?
Yes, I remember when the facility was being built.
Vermont Care Psychiatric Hospital.
Right. And there was a big fight
There was.
about how many beds we needed, et cetera, et cetera. And my memory, if it serves me right, was we were talking about 50 or 60 beds that we needed.
Yes, because at the time, the Vermont State Hospital was at 54 beds.
Okay, and now, so my question is, with everything we read about in the newspapers, we hear about, we hear from the hospitals, that census in the psychiatric hospital is really low. And I'm just wondering what happened.
That's a good question.
I mean, we hear there's a major problem with people having mental health crises.
Yes, and I don't want to take away that from the fact that there are people who present in emergency rooms and either don't meet the medical requirement for an inpatient stay, or there's not a community, an appropriate community setting for those individuals. So there are folks that get stuck. I don't want to take away from that. I think we've seen pretty extreme ebbs and flows for wait times and admissions. If we could show the slide that looks at our wait times, the graph, that might help a little bit. Because what you're seeing is we're getting close to where we were pre-pandemic. So you'll see, 2021, our wait times were quite large. We've seen that start to tick down over time, and I'm talking specifically about adults, and I can talk about youth here in a minute. And so we're seeing that tick down. Our hospital system is also still recovering from COVID. Our staff with staffing and other challenges, as well as our community system. So I don't know if we have one answer that says this is why, but I do think we have a lot of complexities that impact somebody's access to services. We have lots of folks who get into the level of care when they need it and when they want it. We also have a lot of folks that don't. But the census is also a worry for me. I have staff who need something to do and they want to serve folks. But we also don't want folks who don't meet that level of care in a unit with high acuity. And so there's a reason why there's a separation there between folks who are the highest acuity, who are involuntary, and individuals who are voluntary. From our voluntary system, though, like CVMC, they have 6 beds closed because they are having their own staffing challenges. There's a couple of open beds this morning at the University of Vermont Medical Center. So there's not just open beds in the level 1 system. There are also open beds in our more general units. And that can look different depending on what the needs of the referral is. So an open bed isn't always an open bed depending on what's happening on that particular unit or what the individual referrals needs are.
Is there the capability to your point of you have staff, they would like to care for people, to move people around the system as the bed capacities ebb and flow? Or if you are a Vermont Psychiatric Care Hospital employee, that is the only place you work?
That's your only place that you work. Some of that is due to that we are a part of a collective bargaining agreement with the SEA. That's the statewide CBA. Brattleboro Retreat also has their own union. For travel staff, we often find travel staff will jump from one hospital to another hospital within the state, but permanent staff stick with the facility. And that leads to more coherent care for an individual, that's the treatment team that they're working with.
Melanie?
Looking at youth inpatient, I have concerns by the column that says all inpatient beds for youth are at the Brattleboro Retreat.
Yes.
I thought that there were beds like at NFI and other places around the state, and where Brattleboro has more of sometimes a law enforcement edge, like component to it as well. So like NFI, I was understanding a complaint that was just mainly about treatment for mental crisis. So can you help me understand
Yeah.
how we're only having Brattleboro Retreat as the option?
Yes. So the Brattleboro Retreat is the only facility that accepts youth who need hospital level of care. And that's the difference between a program like NFI.
Yeah.
NFI has a hospital diversion,
Mhm.
and that's for individuals who aren't meeting that hospital level of care.
So those beds are still available?
Those beds are still available. They also experience staffing challenges. And so they're typically listed under youth crisis beds,
Okay.
I think. Is that right over here?
So that's where I would have
Correct.
not in the patient. And then my other question is more about your statement about, and maybe I misunderstood it, but moving from trying to get Medicaid reimbursement to going to general fund, and maybe that's not now. I thought we tried to pull down federal money, and with revenues being flat coming forward, I'm just curious about that model. So
Sure.
This isn't the
So-
time.
There's a
Yeah.
they do a report on the, what do we call it?
INFP phase down.
IND phase down, which I actually just recently sent to everyone. So it's very good, explains it, and then we can come back and talk about it another time too. Yeah. Okay, so I want to make sure, I mean, I have a lot more questions about the bed situation, but I think I want to summarize it as this. We have staffing, we have beds that require certain staffing for the level of care that is given there. We need to make sure we are ready to provide that care when it's needed. And it's very difficult to move staff around, although wouldn't that be great? Because then we might be able to reduce our travelers. Is that a good
Sure.
assessment? Okay, so we'll have to come back to some of that. I want to make sure we didn't jump too far ahead, that we don't get to Art's question on the,
Nicole, do you mind coming back? Oh, yes.
okay, perfect.
We've done it a couple
Wow.
times. We got it.
So let's walk through this and make sure we get everyone's questions answered here.
Sure. So we're back to the pyramid. So at the top, you'll see our inpatient hospitalization. That is the highest level of service that's offered for folks within the state of Vermont. So we have one facility currently that admits youth. That's the Brattleboro Retreat. If folks remember from last year's testimony, we are in the process of expanding that to the Southwestern Vermont Medical Center to add a medical component integrated into a medical center for individuals who are needing hospital level of care in youth. So they have a CON that they're currently working on to move that project forward, but at some point in the near future, you'll see that shift and have more than one facility that offers beds for kids. In the middle there, you'll see a general inpatient adult. Those are your general units that exist at the Wyndham Center down in Springfield. There's general units at the Brattleboro Retreat, at Rutland Regional Medical Center, at Central Vermont Medical Center, and the University of Vermont Medical Center. Sometimes there's 2 units, sometimes there's 1, depending on the individual facility. But those are the units that are typically serving our voluntary population. Some folks who are involuntary, who don't have high acute needs, can go to a general inpatient unit and do go to a general inpatient unit when that's an appropriate setting to serve. And then the other box is our level 1, which were developed after Tropical Storm Irene washed away the Vermont State Hospital. And so those are what's considered replacement beds of the Vermont State Hospital, along with the 16 beds at River Valley Therapeutic Community Residence. So I dropped down to the next level real quick, but I can answer questions around the inpatient capacity and questions around that.
All right, did that help?
It does. I just wonder, back to one of the first slides, why the hospital in Berlin was the one that was identified when you have all this
Oh.
other. In other words, do you control this stuff also, or is there a reason it was listed as separate? My
Yes.
pea-sized brain just is.
Yes, I hear you.
I kind of wonder why you had it there and not all of that there.
Because it is Department of Mental Health staff that are staffing that
Oh,
hospital
okay.
and Department of Mental Health staff that are staffing River Valley. It is not DMH staff staffing the other facilities that we
Okay.
have contracts with.
You don't staff all of
No.
that? Okay. Who does though?
The individual hospital does. So for instance, the Brattleboro Retreat, they staff their facility. CVMC staffs their facility. VPCH
Okay.
is the only state-run facility from an inpatient perspective.
This is over here.
Yes,
Now, are those folks that staff this, are they state employees or are they,
yes.
they're all state employees?
At Vermont Psychiatric Care Hospital, they are all state employees unless they're a travel contract.
Okay, but like a Brattleboro Retreat,
They are not state employees.
who do they work for?
The Brattleboro Retreat,
Brattleboro Retreat,
Yep.
which is a separate
correct.
entity totally.
Yep,
It's
Okay,
just like Rutland Regional Hospital is a separate entity, Brattleboro Retreat, UVM. They're all
Okay.
their own.
but aren't they all state folks in the end? Though they are not?
No.
Okay,
They are employed by that organization. They are not state employees.
okay, they're not paid for by, okay, all right, yeah, good.
All right.
Just the icons are helpful in figuring that out. Over to the right, you see the little symbols, private providers. See what I'm talking
I
about?
see,
And then the Department of Mental Health
Oh, okay.
kind of looks like a COVID virus.
Samantha tweeted that.
All right, sorry.
That is all.
So what would be really helpful
Yes.
if there could be because I love this visual. If there could be a second slide that always goes with it, just for our benefit, that the symbols, peer-run services and residential care has a listing of what they are.
Oh, okay.
Department of Mental Health, what is that? Designated and Specialized Service Agency, list the 10 and the 2 SSAs. Is that, because like a glossary or a key or something? Okay. Thank you. Thank you. Pepper?
If I made the statement that we are no longer in a mental health crisis in the state, would that be a true statement now?
It would not be a true statement. We have high need of folks who need support. And mental health treatment is all encompassing, not necessarily inpatient care. And so we still have folks who want psychiatry and who need psychiatry out in our communities, and they cannot access that. We have folks who would benefit from supported housing, and they cannot access that. We have folks who need counselors, who cannot access a therapist. And so I want to make sure that when we talk about an entire system of care, it is the entire system of care. Our conversation right now has been around beds, and beds, I think, is what's easiest to equate care with, but it's really multifaceted and goes across many different levels. I think Allison and I in the department have really worked to have a message that we want folks to have services, whatever that looks like to them, whenever they need it. And so you'll see as we continue to go through our presentation, we've started focusing more on those community services because at this point, we are having some flow in our higher levels. Folks do get stuck though in those higher levels and we can't get them out. And so we're trying to really shift some of that movement into our communities. So I don't think that it's resolved. I think that it's shifted. And the other piece of that is we've been calling it a crisis for a really long time. And how do we move away from everything being in a crisis to responding? Because when I hear crisis, I hear react. And I want us to be able to respond to the needs of our communities. And I think that that's what we're doing. So that was a long answer.
But I think it's important.
Anything
I mean, it was a great question, and I think what's difficult is we have requirements for staffing at the bed level. But, you know, what I think of with your question and your answer is, well, let's move some of them into the community. And then maybe when we need to flow back to more beds, let's go back. It's almost too rigid of a system, it feels like, to do that. But I want us to think about that and how do we best use the wonderful resources we have in Vermont to best serve people of Vermont?
Yeah, I would just add that I think in the inpatient setting, there's the option for travelers. And I think that's the space where you sort of the buck stops and you say, well, you have to staff, you know, there's safety, there's issues. And so we've brought in at the whole nationwide, have brought in travelers there an answer. In the community space, that's not the same, you know, thing. And so there was a lot more focus on resourcing and paying for part-time resourcing for inpatient. And we haven't had that same focus on community. And so you could say that it's stable and that there's beds open. But it's still, you know, when you work there, it's doesn't feel stable all the time, given all the turnover, but at least it's staffed.
Right.
I think we need to start shifting that focus past that.
And that's an interesting point, Allison. And so I am not recommending this, but it's a question I think we should ask ourselves. What if we started staffing with travelers in the community-based system to shore that system up? And then maybe we can start shifting, you know, some of the bed capacity down. You know, I don't know. And it's costs that are really hard for us to take on. But
They're
it's
extremely high.
Right. And they're extremely high. And so but you know, we always talk in here how there's just really no more money in the system. We need to figure out how to move the money and the resources to better flow. And I'm not saying you're not doing a fabulous job, because you are, but it's, you know, it is something that we think about. Ellen, and then
Can I
Daisy,
make one comment to that?
Mari, you first.
Thank you. I'd also like to say that a lot of these challenges around staff sharing from inpatient to outpatient are similar to what your inpatient medical facilities are also experiencing. So that is a healthcare system issue. We have had some community resources contract with travelers. That has happened. And they've sucked their budgets dry as a result of that in many ways. And so I agree we should think about how to have some fluidity in the people who are trained to do the great work and how to serve all of the different levels. But I don't want us to lose sight that that does impact care. And we want to make sure folks are getting really high quality care.
Ellen?
When you talk about getting referrals for your services, you get referrals from doctors, hospitals, law enforcement, EMS, everyone.
Yeah, so what typically happens if they're voluntary, we also have people who refer themselves. And so there are a lot of ways into the system, whether somebody has an intervention with EMS or law enforcement, whether they get assessed by a mental health screener at a designated agency for hospitalization. So I would say there's referrals into the broader system from all of those components.
Daisy?
as we're talking about, investing and, looking at all of these beds, what I'm really excited about is to hear more about where in your programs you're investing in innovation and investing in folks who are already providing care, not travelers. I personally have no interest in investing in travelers in our community-based care. I want to see you investing in peers. We know that there's a lot of promise in our peers and what they have to contribute in community-based care and getting upstream and supporting good health outcomes there. And we'll have a lot more conversation, I think, in this committee soon about that. But I look forward to just encouraging you all to invest more in the community and the lower level of care and hopefully getting ahead of things before people need inpatient. Just want to support that.
Thank you. All right, and then we'll move on.
We've been having the conversation about how do we increase resources for community level care for so long. It's a great idea. I would like to do it, I know we've made strides. And it has been incremental. We're a small state. I get it. Was just to say, we still have a lot more work to do in providing more resources for permanent staff and peers at the community level. I also want to say, as a union member and leader within a system that does have staffing issues, like you mentioned, our collective bargaining agreement that we negotiated does have some unique staffing solutions that include a float pool, so that it's not mandated that people float from one facility to another, but those that like to and have the skills and ability could do that. Is that something that you've negotiated or talked about before?
We have some challenges in that with the IMD, or the Institute of Mental Disease regulations, which do not allow us to share staff. So that is a challenge for DMH. It's also a potential challenge for the Brattleboro retreat. But we are looking at folks can float in and out of different shifts voluntarily at BPCH and River Valley too. But we are currently taking a look at those regulations that don't allow us to share staff. Because we have staff. Right now, we're not sharing between our own facilities because of the federal rules around sharing staff.
Maybe Vermont could have yet another pilot program.
Maybe. Yeah.
So sorry, Brian Representative Chena is on Zoom, and I can't see you, Brian, but I know you have your hand up. So do you have a question?
Thank you. But Representative Cordes basically just asked it, and the commissioner, answered it. So thank you.
Okay, thanks. And Brian, if we're not getting to you, feel free to say, "Hey, I'm here." Because I just can't see you.
Thank you, and I'm on my way, so I'll see you all in a little bit.
Great, Alyssa, and then we really are moving on.
Maybe this is too open-ended of a question, but Copper's got me thinking, are we in a mental health crisis right now? And I'm looking at the system of care, but I'm thinking about all the people right now that are not in the system of care, who need to be in the system of care. And I'm wondering, number one, do you think about that and worry about that? And if you could wave a magic wand, what resources, what types of things do you think that we are lacking to be able to bring everyone who needs, support into a system of care? So what would be your perfect What are we lacking?
Representative Houghton asked this question about almost 3 years ago, and she used the words magic 8 ball. And I cried, but I'm gonna try this.
That will be like, no, you're not getting it.
Take it again.
Yeah, what I'll say is I'd like to get to some of the things that we are doing, because it's part of the magic wand. It's part of the magic 8 ball. And that is linking back to folks being able to access treatment when and where they want it. Versus this, I think we have a lot of work to do as humans to move away from, I know what's best for you, you need this, and shifting into, actually, I know what's best for me, and this is what I need. And programs like our mobile crisis response really provide that opportunity for folks, because it's a person identified a crisis or situation. But I absolutely think about the folks who have not accessed our services at all, or accessed the substance use services at all, and are reluctant to do so for a variety of reasons. But I think we've made some investments in some upstream that gets maybe like, my mom had a magic wand and it was long, and there was like these things that kind of, maybe we have one of the pieces to that and we continue to build on it.
So yeah, so let's move forward, because I think that's a good segue.
So I'm gonna transition over to Deputy Crump for this, and is after this when we talk about, okay, so I'm gonna actually let Jeremy come up, and when we get to his content, we'll get going.
Great. I do like that question, even though it's hard to answer. And I think to Topper's point earlier, I think one of the things about if we're in a mental health crisis is that I mean, you could just ask anyone in this room, like, how are you doing? I mean, it's stressful. We're coming out of a pandemic. Most people aren't doing well. And what we're trying to get into the conversation is that doesn't equal beefing up or adding numbers to inpatient beds. It may at times. I mean, when we didn't have them, when they were offline, that was a very big deal. And if you worked in the community, you felt it. And it actually contributes to turnover in the community if you don't have inpatient beds. Because then when I worked as a crisis clinician, when you're out in the field and you're doing that good work and somebody does need it and it's not there, it's incredibly demoralizing for you with the work. So they're really important, but they're not, this silver bullet to what we're trying to do here. And I think so what we're trying to do with this investment is the one thing that came out of post-pandemic, or during the pandemic, actually, was when this opportunity came, is federal dollars for some additional investments. So some of the things we're going to talk about today is what we've done with those, and they've been infused into home and community-based services. So we'll talk a little bit about that. But this is our wheel in terms of what we're thinking of how we need to approach getting somebody into the system at the time when they need it. And so we look at someone to prevent, someone to call, someone to respond, and somewhere to go. And this committee's been involved in someone to prevent for some time. And so some of the we brought in new positions. So for example, the trauma and resiliency position, we have our trauma prevention position, Kaya Ganguly, who, if you haven't had her come in, she's phenomenal and has done some really incredible work. And when I think about that magic wand, I think of that it can't just be getting treatment for folks. It has to be, hey, where do you work? What is that culture like? How does it support your mental health? Where do you go to school? What is that culture like? And a lot of Kaya's work is going in and doing education and training on how to make trauma-informed spaces so that people just go about their daily lives. They're not experiencing undue stress. We have a suicide prevention director, Chris Allen, who I'm sure you'll hear from this session. And he's working on a strategic plan for suicide prevention. And then we also have some community investments. When we talk about this access to psychiatry, I think to your point about floaters, we are trying to think differently about how we can staff things when there aren't enough staff. Nationally, there's a psychiatry shortage, particularly child psychiatry. So the Vermont Child Psychiatry Access Program has been this really unique initiative that offers access to child psychiatry for free to providers in the community, but without having to call and say, I need to make a referral, add this person to your list. It's timely, it happens, same day. So there's a lot more access, but they're not becoming a patient of that psychiatrist. So those are the types of things we're going to need to be trying out in order to
Hear more about that access.
Okay. Someone to call, so 988, and we'll show you some numbers about how that's going, but it's been really successful. We're really proud of what Vermont's done, and CSS and NKHS deserve a lot of credit. They've stood up these 24/7 call centers. It's highly utilized, seems to be really well received. And that's a place where we're going to look to make some connections with if you do need a referral or mobile crisis response, which Jeremy will talk about, we're looking to build some connections there. We still have the crisis text line. You might see these little red things that say, text VT to 741-741. A lot of our LGBTQIA plus youth use that service. It's promoted by Outright Vermont. They feel really seen and heard through that service, and it's something we're still holding on to despite 988 because it's been such a positive experience for that population. And then the Pathways Warm Line, which has been 24/7 since COVID. And when we talk with our standing committee at the Department of Mental Health, some of them man that phone line. Say man anymore. Thank you. And if you're somebody who wants to talk to someone who knows what it's like, what you're going through, what I love now is we have those options. If you may want to choose 988, you may want to choose the Pathway Support Line. Both are available. Someone to respond is our mobile crisis, which I won't get into because Jeremy's going to talk about that. But it has this peer component, which Daisy spoke to, which I think is very exciting. And then obviously our designated agencies and special services agencies. And I think we have a slide here that talks about some investments specific to staff retention and recruitment. I assume you'll hear from Vermont Care Partners about that this session. It's definitely still a major issue with staffing throughout the community. And then somewhere to go, that's where the youth inpatient facility. And we spoke to, there was a pretty specific need. We had youth stuck in emergency departments because they had a medical condition and a mental health issue. Brattleboro Retreat wasn't equipped to serve. So that will be this new inpatient facility at SVMC. I love that we just kind of skate over now that we have River Valley, but that was a really big deal.
That was really big deal. Yeah.
Really
big deal.
Yeah. And it's in existence and people are there. So that's, I think, this year's news. And I'll pause if there's a question, but the last couple of things were just the residential. Oh, before I pause, I am going to speak a little bit to this children's residential piece because it has been, you've probably heard many times over the years, kids who need residential go out of state. And it's costly and it's not good care for our youth who then need to come back to their families. So we are looking to move in that direction in Vermont. Right now, the only residential, the hyper residentials at Washington County, which also experience significant staffing issues. So their beds have been much lower capacity.
All right, we have a couple questions. We have Leslie and we have Art. We have Alyssa. If I missed someone, let me know. Daisy.
Very quick. Are all 16 beds at River Valley okay?
They're only staffed now for 10.
Leslie, you had a question?
Yeah, my question's kind of structural. I mean, I kind of think about VBH, the Department of Health, they have places all over the state with offices and providing direct care, as opposed to you who do it through designated agencies. And I'm thinking about community services, and have you ever thought about providing direct services to the community through DMH rather than through this third party pathway? And I'm new to this whole thing. I don't know how it got developed that way. But sometimes I worry about that system of that handing it off to that other group.
I don't think we really have considered that. And right now, I think the designated agencies are their, independent nonprofits that we work with through contracts. They're a pretty collaborative relationship. So it hasn't been a discussion for the state to be taking over that I think each region has their own cultural needs and we see them a whole heck of a lot. So we really, I feel like we have a really good sense of what's going on in those communities. So I don't think that's really been on the table.
Just sort of building on Leslie, because as soon as this popped up, I saw trauma and resiliency. What did the states, what did you see as your role in flood response? How were you, I mean, no, we outsource this to all the designated agencies, but did the state see a role in support? What were you doing around trauma and resiliency specific to flood this year?
Sure, I'm sure you have a lot to speak
do.
to about this.
Yeah, you want me to hop in? Yeah. Sorry, you hear me? I was gonna get off easy, but here I am. Yeah, so the Department of Mental Health specifically did a few things. We applied for a federal grant to contract with folks. Some are with the designated agencies, some are not, to provide door-to-door crisis work for individuals who were impacted by the flood. And that crisis work is a little bit different than screening for hospitalization. So it was, and it continues to be active, working with folks and connecting them both to some mental health supports, substance use supports, but also FEMA supports and other state resources that could assist someone as we all work through impacts for the flood. Those were individuals and individual based. So that's called Starting Over Strong. And so that program is currently active. Additionally, there were DMH staff who participated in some of the what were they called? The disaster recovery centers that primarily in the central Vermont area, Lamoille and Washington County. So we had some direct interaction with folks, but then we also applied for and received a federal grant that we have supported communities.
Thank you.
Mhm.
All right.
Yeah, that triggers another question I had. Your folks that go door to door, is this about, and you refer them to various places, and I get that that's a common sense thing to do in that circumstance, but are you also dealing with their mental health piece of the flood? Is that what, counseling, trying to get them to understand that this might be temporary and life hasn't ended for you? I just wonder if you do that type of counseling at the same time.
Yeah, so
or no?
those are all the interventions that we're working with. And if somebody needs something longer term, they'll help with the handoff to that individual.
Okay, but my real question.
That was a little warm up.
I'm sure many folks in here have driven down some of our streets and towns and stuff and seen individuals that might need some mental help, mental counseling, mental health. These places you talk about, Allison, these 4 quadrants of care, can a person seeing that call in and say, there's an individual on Main Street, he's gesticulating, he's screaming. I wonder what, and trying to think it through, what place an average citizen has in referring that to someone. And if there's, and this might sound, if there's any legislation that could be introduced to get those people voluntary help, or whether that's even appropriate, because I've seen it happen, and I've seen people that really need to be in some place, it seems. And I just bring it up, and I don't know if it's even addressable.
Yeah, you go first.
I mean, I think here's the issue is that there is clear law around this and for good reason, right? And so historically,
Absolutely.
people have been involuntarily hospitalized inappropriately. So the statute is there for a reason and the threshold is there for a reason. So where that line is really around safety. And if they are if they're unsafe for themselves or towards others. And I think the safety word, right? If they're, as a citizen watching somebody, you might feel is suffering. I can get why you might feel that's unsafe for them. However, if they're not interested, there's nothing
Nothing that
illegal
can be done.
about
Okay.
somebody being symptomatic on the street, right? And so I think the biggest thing to think about is, can they be approached and asked if they're okay? That would be a pretty nice human response. And then you might get something out of that conversation. Maybe they don't have a place to go back to. Maybe they don't have food. Maybe they're out in, negative degree weather without, and there is something you could do with that,
Yeah,
but not just for being symptomatic.
okay, thank you.
Great. Okay, we need to, can you just jot it down and then but let's keep moving.
Okay, so in a calendar year, so the legislative testimony for that we brought to you was around mental health urgent care, statewide mobile crisis response, 988 workforce recruitment, CCBHC's forensic facility, and SVMC. And so we wanted to talk through some of these targeted investments, because I think when you talk about, to Representative Black's question of, does it, sort of keep you up at night that people can't access the system when they need it? And 100% yes. Commissioner Haas did cry a few years ago on this stuff.
Okay, we don't need to.
I found it very heartening.
I did too. Although I was a cause of it, but yeah.
And it does. And I think when we think about parity and we think about how you access care, we knew that we needed spaces to catch somebody and when they're having the moment to say, okay, haven't been doing well maybe for weeks now, but today I've got a space in my schedule or time away from my kids, or I'm just had it and I'm ready to go talk to somebody. We didn't have a lot of spaces that you could just walk into. And so when this investment opportunity came for home and community-based services, so the federal government gave out, didn't just give out, you had to apply and it was a bit arduous, but funding to invest, but it had to be in your community. So it couldn't be those inpatient beds we talked about. And so we went forward and put out a request for proposals for mental health urgent cares. And so I think the next slide talks about where we have them thus far and where they're yet to come, but on their way. And so we left it a bit open for communities. We gave a list of options. You could do one specifically focused for children and youth. You could do one specifically focused for adults. It could be a peer-based model, which is often referred to a living room model, or it could be more of a medical model through a classic urgent care. And then we have one in Burlington, the police department, that's specific to shifting police response to a therapeutic response. And that's called Burlington Cares, which is based on the Cahoots model in Eugene, Oregon. So those were on the list. Our criteria were that it had to be aimed at reducing utilization of the emergency department, reducing police response to mental health crises. Those were two kind of major pieces we wanted to impact in terms of having people access something alternatively to those two options. So United Counseling went forward. They had been working with a PUC, and I probably heard through that, and with great success. And so this opportunity allowed them to expand their hours and sustain the program. And then HCRS also engaged in a PUC based on that same model, which is urgent for kids. Laurel County also went with a children's focused. They're calling theirs EPIC, which is a pretty specific psychiatric intervention program based off one nationally. And then we have two peer-based ones, one at CSAC and one at Washington County, and those are both open as well. And that is more of a person-driven, as Commissioner Haas spoke to, less about I'm coming in the door asking you what I need versus I'm coming in the door saying, I know what I need. You're going to talk with me to identify what's best for me to get my needs met in a little bit of a different model way and met by peers at the door. And then this Burlington Police Department program, which is pairing specifically a medical professional and a mental health professional. And in Burlington, they're trying to address the specific issue of substance use and mental health crises that has a lot of wound care needs. And so putting those two together and going mobile is an attempt to try to meet that need. And then there's two more coming. One in the Northeast Kingdom that was in the governor's budget last year, so that has sustained funding.
That's the family room model,
So it's the front porch.
front porch, I know, something like that. Thank you.
Yeah. And so theirs is unique. They have an urgent care in the front, or they have crisis beds in the back. So that's the type of model they're building, but it also involves peer-based services and access to psychiatry. And then the other one, which is a really unique amalgamation of providers. It has UVM Medical Center, Howard Center, Community Health Center of Burlington, and they're working with Pathways to potentially also provide some peer support. So that group came together to look at putting an urgent care model for kids and adults in Chittenden County. And so we're working on the contract right now. It is finally moving for all of these spaces. A lot of issues can happen when you're trying to find a location. So I know for Northeast Kingdom, that was part of the delay, was them getting approval for that. And in the Chittenden County region, they also had to move their original location. But the contracts are moving. These ones are already signed in the Northeast Kingdom, and UVMC Howard Center one should be signed in the next 2 to 3 months.
So a couple questions. Are there any early data showing how successful they are?
Yes. Do we have that in the notes?
I know that Washington County,
Sorry, Jeremy, can you introduce yourself to the rest?
yes, my name
And
is,
for all of us, because we haven't met you yet.
my name is Jeremy Terry, and I'm the Director of Crisis Programs for the Department of Mental Health.
And I'll just pause quickly that alone is a big deal.
Yeah.
And that wheel that we had, we've now, everything that we've listed through mobile crisis, 988, urgent cares, those are all new types of approaches to bringing care to Vermonters. And so Jeremy will be.
Great. Great.
I thought I had the number in my head, but I don't want to make it up.
Okay.
But one thing that I do remember is in Washington County, their living room model, every single person that went there for the month of December said that it diverted them from going to the emergency room.
I think that number was in the 50s.
Yeah, I want to say 50 something too, is how many interactions they had in December.
Great. And for each of these, is this a year contract, couple year contract? How long does this last? What's the funding mechanism? And then when does it go away?
Yeah, so funding for all of these programs, anything using HCBS FMAP dollars has to be expended by March of 2025.
We have another year. So next year, potentially these will be in a budget request if we deem them successful.
Yes, we have some very intentional program evaluation metrics.
Okay.
So you're looking at per region, how much utilization happened there, as well as diversion from emergency departments. And then we'll bring that folks to consider.
Okay. So I think I'm just throwing it out there for potential. It would be great at some point to have a representative from each of these entities come in and talk to us and explain each of these and provide some of the metrics, since some of them, by March, some of them will have been in for at least 6 months. So Jeremy, if we can just flag that for future, that would be great. Any other questions on this?
It's exciting.
It is very exciting. It's very exciting. Yes, Topper?
Can you just briefly talk about what kind of coordination the Department of Mental Health has with Dale in terms of treating individuals?
Briefly.
Briefly?
I could try, and I might let Commissioner Hawes also step in. We certainly a great deal, because on an individual basis, for example, we meet all the time. If there's an individual who presented at the emergency department and it's unclear where they might be best served, there will be a team that comes together, and that team is identified and already knows each other quite well at the state. I think there's larger initiatives just in terms of right now, anything that we're moving forward with, like, conversations around higher levels of care needs. the commissioners meet and discuss kind of what laws exist right now for somebody with a developmental disability that qualifies them for a level of care or not, and what needs to be adjusted or not. Those conversations are being had on a regular basis. The system hasn't been necessarily built to be integrated in that way, both medical, mental health, or developmental. And I know the secretary has a real intention to break down those barriers and move towards more integration. But I'll let you speak to any other specifics.
No, I think you summed up that well. There's a lot to unpack with even how the different departments and services are funded. Because they're funded quite differently. But down at the surface level, if somebody needs stabilization for a psychiatric illness, then we're going to serve them in that appropriate place, developmental disability or not. So we have individuals who are admitted into psychiatric inpatient units who also have an intellectual disability. So it depends both on the person, what their plan is within their DAIL service delivery system, and how we can complement that. So we also have folks who are who have intellectual disability and maybe schizophrenia. And we collaborate closely, the designated agency collaborates closely across their teams to make sure that person's getting the services that they need.
And just a follow-up question.
Yes.
What are you doing in terms of, if a statement is made to an individual, no, we can't provide those services because we don't have staff.
Oh, dear.
Mari, can you mute yourself, please?
It might be helpful to have a little more context of that. So staffing, you could get a message that we don't have enough staff to open all the beds to serve somebody.
I'm not
I
talking
think
about
it's-
beds now, I'm talking about services provided within a community.
For folks with underneath the DAIL
Yeah,
program. I guess I would ask that Dale speak to that. I can't speak to how they respond.
I was just trying to figure out
Yeah,
what the cooperation or coordination was.
Yeah.
between Department of Mental Health and Dale. And specifically, with
around
people with,
staffing. Okay,
staffing and serving people with intellectual disability. Okay, so you'll probably hear more about that in the coming weeks.
okay, great.
All right. Keep going.
So,
Hi, Jeremy.
thanks. Like I said, my name's Jeremy, and I'm very excited to talk about 988 and Mobile Crisis, two of the new programs that is in Vermont. So Allison talked a little bit about urgent cares, which is in that pie, somewhere to go. So we're trying to build a crisis continuum in Vermont for a client-driven system because everybody's needs are met differently. So if someone wants a place to go, they'll have an urgent care to go. The mobile crisis section is someone to respond. So DMH contracted with HCRS, the designated agency that covers Windham and Windsor County, to provide statewide enhanced community-based mobile crisis services. And they subcontracted with the other 9 VAs in the state to provide this statewide. I don't want to get ahead of myself, but I've just heard a lot of comments today, and one about like sharing staff is one thing that's different about this is the DAs will work together to be able to provide the services statewide if the specific DA doesn't have the staff to provide that response within their county. So that's a cool, exciting.
Yeah, that's great.
And so you might be asking, how is this different than the crisis services that we have now? So it's all client driven. The client identifies the crisis. They can call 988, they can text 988, they can call the designated agency crisis line to request a mobile crisis response. And the definition of a crisis is different for everybody. And so whatever the client crisis is, the mobile crisis team will go out to do an individual assessment, de-escalate, provide services, provide peer support, whatever support that person needs. And of course, it'll look different for everybody. The client gets to decide where you meet, whether you want to, if the client wants to come to the office, the client wants to meet at Dunkin' Donuts, if they want to meet at home, wherever they want to meet. The mobile crisis team can go anywhere in the state of Vermont. This also includes substance use crises. So currently, the crisis system that we had prior to January 1 only saw mental health crises. Of course, co-occurring issues as well, but oftentimes they weren't able to see somebody until they were not intoxicated anymore. Now, if you or a loved one is having a substance use crisis and they're ready to seek help, they can call mobile crisis to go out and help refer them and get them services for their substance use.
Great.
This is also a two-person model. So it will include a clinician, and the heart of this is to include someone with lived experience. And so this is new for all the DAs, and so they're going to start growing their peer workforce to be able to have a clinician and someone with lived experience to go out to be the two-person model. Right now that's happening. But as the DAs build their workforce more, right now it's a clinician, and it can be like a case manager, a therapist, really any other DA staff can go out as the two-person model. But I just want to stress the heart of this is to include peers and people with lived experience. There's also follow-up services available. So again, this is different than what the crisis services do now. Mobile crisis will be able to do follow-up services up to 3 days for adults and 7 days for kids and families. Oftentimes crises aren't a one-time, you're done, thanks, and the team leaves. The crisis might continue. And so this will allow for more follow-up services, checking in. What else do you need? How's the safety plan going? Let's check in about what we did yesterday and the day before. Did you think about what we talked about? Do you have any questions? And the goal of that is to keep people in the most comfortable environment possible, keep them out of the emergency room, decrease law enforcement. The hope is that they'll call us, they'll call mobile crisis, we'll go out and support them versus those other entities that I described. I don't know if I'm going too fast.
No, you're doing great. Very exciting.
And lastly, again, this is just how it's different than what we did prior to January 1st. Our goal is to have a rapid response. We're aiming for an average of less than 60 minutes. You might have heard that there's long waits right now for crisis services. With mobile crisis, our goal is that you get a rapid response, rapid de-escalation. We don't want to see people suffering. We want to get out there as quickly as possible to help people. So that's our goal going into this new initiative here. We expect this to have a really big impact. We want to see a lot of people. We want a quick response with trained staff. All mobile crisis staff are required to do a list of trainings, including trauma-informed care, de-escalation, harm reduction, and they're required to do all this. So we hope that they're well-trained to go out there and be able to respond to a wide variety of crises. And the two-person allows for, a peer and a clinician sort of will look at it differently. The clinician can focus on the assessment, if a risk assessment needs to be done, mental status, where the peer can connect with the client differently, provide any tips and tricks that they might have learned if they went through something similar. And the hope is that combined is a really powerful intervention. And then if there's multiple loved ones or a family in a crisis, I used to be a crisis clinician, it's very overwhelming alone. So now you have two people to be able to de-escalate the situation. Maybe you can meet with parents outside and the clinician can assess maybe a child inside, but it really allows for a more robust response. And a fun number, there's, as January 1, so what is this, 17 days old? There's been 57 mobile crisis responses in the state, and that's a minimum number. I got that number on Monday, and I didn't hear from all the DAs. Another fun fact is MKHS has done 7 since January 1st, and all of them have been a clinician and a peer.
Great.
So we hope that this is going really well in the state and people utilize this new service.
Very exciting. So, I know there's a couple questions. Leslie?
Thank you. Yeah, totally cool. I have a couple questions. What does completed mean? On the bottom line,
The 57.
yeah, like, so what's an endpoint that you're looking for?
Yeah, so I just mean by completed as the DA responded to a client in crisis in this model with the mobile crisis model that I just described.
Okay, so they showed up, but we don't know what the outcome of that. And
No.
so is there possible to follow that?
Yes, so our lead vendor, HCRS, meet with them 3 times a week. And we have an encounter form, which is required for every mobile crisis encounter, and they're gonna share that, all the DAs will share that with HCRS, and then HCRS will share it with us every month.
Okay,
So we're really gonna get into the heart of it next month. Our data will be due February 15th for January,
great.
and then, yeah, we're gonna,
Yeah, because I'd like to know what happened.
yes, me too.
Yeah, of course you did.
Yeah.
I think it's totally cool that it's the whole state. I was wondering if I may, on the slide before, you were mentioning all these different programs all over the state of different DAs. Could someone from Wyndham County go to Addison? Even, borrowing transportation, let's say, but so every program in the state is available to every person in the state is my question.
So access, yes. So for example, if you were driving through and you needed to access urgent care, you should access urgent care wherever you may be. Whether or not that means you would get enrolled in a program at that designated agency, there are catchment areas. So if you, lived in St. Albans, but were driving through Chittenden County and you needed to access the urgent care, yes, please do. But you likely wouldn't get enrolled in services at the Howard Center. You would then get enrolled in follow-up services through the NCSS at its Albans.
Yeah, because I'm thinking sometimes, there's not a good match. HCRS doesn't work for this particular person. Could they move outside of that system to another system? But what I'm hearing is maybe not.
It's not that there's no choice. People do sometimes access counseling at different designated agencies. And there is required choice for who your case manager is, things like that when you're in the CRT program. But we designate the agencies to serve their catchment area.
Yeah.
So that's the general default.
I know that's the tension, but sometimes it doesn't work.
I just wonder, keeping in mind, we're only 17 days in. Do you have a sense of how the initial point of contact with the 57 responses, is there an overriding method yet identified? Like, is it 988? Is it law enforcement? How is this?
The majority of the referrals are self-referral through the DA, the client calling the designated agency crisis line.
Okay.
And we're working with HCRS on a marketing plan. We're gonna hopefully launch a website this week. And it's gonna be on the radio on every point in Vermont. We're gonna work with WCAX. So we really want to get this message out, of course. It's just gonna take time.
And from Porch for Amanda.
Yes.
All right, thanks.
So, sounds like a great program. I have one question. Is this limited to people who can speak for themselves?
No, this is open for any Vermonter, regardless of age, insurance status, diagnosis, presentation. If you're just visiting, this is for everybody in the state of Vermont. But
Okay.
it's a voluntary service. So you have to want it.
So when we talk about client identified crisis, client identifies where to meet. So how would you do that? Through a guardian?
Yeah, or family or any loved ones.
Anyone can call.
Yes,
Right.
yeah,
Okay, good.
but the client has to want to meet.
Okay, that's my point. If a person can't do that for themselves,
Then I think that, I don't want to speak for the DA, but I think that the designated agency or the team that's responding would rely heavily on how normal communication happens with that family or the situation. And however they communicate, if the loved one is saying like, yes, they can't communicate for themselves, but I'm letting you know they're voluntary, that they can go out and do an assessment and figure out if the person's really voluntary or not and get eyes on the situation. They would still be expected to respond.
Art?
So back to my point a little while ago. You get calls, you get people and they want to be in. I call you and say, gee, there's a guy here looks like he's got some real needs. What would you do with that? What would, if anything?
Yes.
Tell me to refer to law enforcement? Would you, like I say, someone walking down the street, screaming incoherent, say.
So one of the good things about mobile crisis is the team that also does emergency services that might do the involuntary assessments, they're the same team.
Okay,
So if that example, someone's screaming downtown on Church Street and you call Howard Center and be like, this person really needs some help. They might know who the person is if you describe them. They have a street outreach team that is also on Church Street. They might call street outreach and say, hey, can you go down there and see what's going on? You might know them. Can you talk to the person? But it wouldn't be a mobile crisis.
right, okay,
Outreach.
that's fine. That's kind of what I thought.
A couple quick questions. Funding for this is through the home and community-based stream as well, or is this different?
No, this is different. And so we requested a budget for mobile
Right.
crisis.
Okay. And so is it in our base budget now? Yes. Okay, great. Great, thank you. Let's do 988 and then we'll take a break.
So 988, also very exciting. This is the nationwide 3-digit suicide and crisis lifeline, also known as the National Suicide Prevention Hotline. So that's synonymous. They changed the name. So it's 988 Suicide and Crisis Lifeline. And the message that we want to get out for 988 is that you can call for any reason. It's really hard to say, it says up here, if you have a mental health related distress, thoughts of suicide, mental health or substance use crisis, any kind of emotional distress. I know people can get hung up on, should I call them? Like, I don't know, I don't want to bother them. So the message is really, if you are in distress about something, you should be calling 988 and you'll be connected to a crisis counselor who can guide you through maybe whatever you're going through, listen to your concerns and help you. The overall long-term vision for 988 is nationally that this becomes part of a larger crisis continuum that is connected with mobile crisis. You can call 988 to get mobile crisis. And the goal that SAMHSA also shares is that this will become a national goal. And that's also a goal in Vermont, which I'll touch on. So one awesome thing about 988 in Vermont that I can speak to is if a Vermonter calls a designated agency crisis line right now, they might get a paging system and then they'll get a call back. With 988, you'll be connected with a live person right away, 24/7. And right now, Vermont is NKHS and NCSS share that, the 24/7 in Vermont. And in December, they answered 86% of the calls. There were 966 calls, and we answered on an average of 15 seconds. Our goal is to answer 90% of the calls, so we have some work to do, and answer less than 20 seconds, so that the caller would have to wait less than 20 seconds. If we don't answer the phone, we also contract with Headrest, which is in New Hampshire, and they'll answer calls. And then if none of those three can answer, it'll go to the national lifeline. So again, a crisis counselor answers. We want it to be as many callers in Vermont getting a Vermont crisis counselor because they know the system better, they know Vermont better. And, the hope is that they can connect you to the Vermont system because they live there and they work in Vermont.
Great. It's great that you're answering so many calls in the.
Yeah.
I'm looking back on last year's numbers just to see, how's the texting going? Are you getting a lot of texts
Yeah,
through 988?
yeah. We respond 24/7 to text and chat.
Okay, I just wondered if maybe the text was becoming a little bit more popular or.
I don't have the numbers on text and chat in front of me. I can certainly circle back and get that for you.
Okay.
Yeah, smiling because he had them and I said, that's just too complicated.
We want numbers.
Well, if I hadn't been looking at last year's numbers, I had pulled up that I was like, oh yeah, what about the chat? That's
It would be
exciting.
great if you could just extend each month.
Yeah.
That'd be great. Thanks.
I just want to point out, last December, or December 22, and granted it was new, starting in September, but there were 605 calls in December of 22, and you've got 966 in December of 23. So
That's great.
that means that people are using it.
Bobby?
Oh, I just wondered if the text end up becoming voice chat, I mean, voice communications, or they stay text? You know, if there's like a protocol for turning a text into a voice to voice communication.
I'm sure it can, because it's the same agency. So if you're calling, if you're texting 988 and let's say NPHS answers, it's in the same home.
Okay.
So you can connect.
Yeah, because I mean, some people might text, but then they might benefit from actually hearing a voice. I just wondered if there was like a protocol for that.
Yes. I don't know if there's a protocol,
Okay.
but yeah, that's an option.
And I think what will be important as we're hearing all of this is to invite all the agencies that are doing the work to come in. And we'll have like another morning or afternoon where we do that.
If I had
It will be helpful. Yeah.
One other thing is we're hiring, not we, but the NKHS, NCSS, and HCRS are hiring 988 service coordinators. So NCSS and NKHS both hired theirs. And there's one there, and HCRS will have two. And the goal of that team is to work together to seamlessly create a crisis continuum to combine 988 with mobile crisis. Not combine literally, but like make it very easy for Vermonters to call 988 and get access to mobile crisis through a dispatch system yet to be made. But we're really excited about that work and excited for HCRS to hire those two to really start that work. And they'll be doing that at the direct service level. So they're really going to know what's going on.
That's great.
I may have missed this, but did you mention anything about the integration of 988 and 911 and comprehensive crisis response?
Yeah, so 988 works with 911 and mobile crisis works with 911. The way that they sort of always have, in that 911 knows 988 exists and 988 can call 911 if there's more of an emergent immediate crisis response, whether it be police or ambulances needed. And mobile crisis team does the same thing with 911. Down the road, our vision, we would love to be able to transfer a call 911 to 988, but that is, it's a big work in progress. Because right now they have strict policies that they only refer to those three things and there's liability involved. And so we've been educating 988. DMH meets with Vermont 911 to sort of talk about the program, talk about mobile crisis. So we're keeping them updated to share with their team so they know it's available in the state.
Is this a federal policy hurdle?
The other states that I've heard from have run into the same issues. So my assumption is yes, but I'm not 100% sure.
Thank you, Jeremy. This is all really exciting.
Representative,
Yeah,
can I add in just on Representative Rebecca's question? There is a upcoming policy academy to look at the collaboration and the potential barriers with 911 and 988 that DMH will be applying for. That will be hosted in Arizona. And it's a national, I think tank to talk through what those potential federal barriers are.
Excellent.
And break those down. So we're excited about that opportunity as this continues to evolve. But wanted to put that on your radar. So I think that's
So it's something you're going to?
That's great.
You have to apply.
They have to
And-
get chosen.
Yeah.
Who would? I don't know. We have to apply for that, but that is something that we'll look to do so that we can get a team of key stakeholders down there and really get in to what barriers are relevant to Vermont and move to that.
Who's hosting it? Is it SAMHSA?
It is SAMHSA, yeah.
Great. So I think what I want to do is take a 10-minute break and then come back, because I know I have the lovely DMH people until noon, and switch to the Vermont Child Psychiatry Access Program, hear about that, come back to DMH, and then if Vaz is okay, and then we'll do Vaz at the end. So does that work, Devin? I'm not sure Amazon yet, but so let's take 10 minutes. Please be back right before 11:15.